Hello everyone. Okay, this is a review of chapter 20. So in this PowerPoint, I'm going to discuss maternal complications in pregnancy, and these include cardiovascular disease, anemia, autoimmune disease, infections, HIV, substance abuse, and adolescence. So we'll begin with cardiovascular disease in pregnancy. We know that it complicates about 1% of pregnancies, and it is on the rise. It does remain a significant cause of maternal mortality, especially now that we're seeing older women having babies, delaying their childbearing years for their careers, and also the obesity epidemic. There are two major categories. There's heart disease, which includes acquired heart disease and congenital heart disease. Now, acquired heart disease occurs throughout the course of someone's lifetime, where congenital heart disease, they're born with the condition. So congenital, again, involves structural defects at birth. A lot of them are picked up now on ultrasound in the fetal period. Ultrasound has come a long ways where we're able to detect a lot of these congenital defects, but some may become unnoticed and may be discovered later on. Many women can successfully accomplish pregnancy with a low risk if the appropriate care is given. And again, this is going to be highly dependent on what the condition is. So if they have an uncorrected tetralogy of Fallot, transposition of the great vessels, and Eisenmenger syndrome, or one of these, they should avoid pregnancy due to increased rate of mortality. These carry a very high mortality rate. These are all cyanotic heart disease conditions where they lose oxygenation. Now, Eisenmenger's is a really bad thing to have because it is aortic dissection, and what tends to happen is due to the increased blood volume that occurs with the normal changes of pregnancy. It's just too much pressure, and you've got increased cardiac output, which further puts more stress on the heart and the blood vessels. So complications for the fetus include growth restriction. Again, you have a deprivation of oxygen and nutrients when mom has a heart condition. Preterm labor and birth, and a lot of these cases of preterm deliveries are due to the mom's condition deteriorating. You have an increase in fetal and neonatal mortality dependent on the severity of maternal disease. Again, some of these conditions, they should absolutely not become pregnant. So acquired heart disease, they affect the heart and associated blood vessels that develop over a person's lifetime, as I had said earlier. These include coronary artery disease, coronary heart disease, rheumatic heart disease, diseases of the tissues, valves, pulmonary vessels, and aorta. So it is becoming more common due to women delaying childbearing, as I mentioned earlier. So there are classifications of heart disease. Now these don't change. They're true for everyone, even pregnant patients, but even patients that aren't pregnant. So it classifies the extent of heart failure and how much limitation they experience during physical activity, normal breathing, and the degree of shortness of breath. So that's really what these classes tell us. And you have class 1 being the most mild, where they're pretty much virtually asymptomatic and not really showing any signs of heart disease. That can range to class 4, which is the most severe. They are symptomatic even at rest or with physical activity. They can't carry out any physical activity without having discomfort, and they have angina even with rest. And they have severe cardiovascular disease. And class 2 and 3 fall in the middle there, but just be aware that they do increase with severity as the classes go on. So the pathophysiology, and we talked a little bit about the normal physiologic changes of pregnancy early in the term. And imagine if you're putting insult on the injury. If the patient already has a pre-existing heart condition or they develop a heart condition, these changes are going to overwhelm their cardiovascular system. They have increased cardiac workload and myocardial oxygen demand. and it does increase morbidity and mortality in women with cardiovascular disease. So the cardiac output in the first trimester begins to increase, and then you have the peak between 20 to 24 weeks, and from there continues to increase to 28 to 34 weeks due to the 30 to 50% increase in blood volume. And patients with cardiac disease often can't tolerate this change. So here you've got that 28 to 34 week range. So that's why these babies are delivering early, because they are peaking out and plateauing about that time. And so a lot of times this can become dangerous for the mom, so we have to get her delivered to save her. Many with certain heart conditions may be able to tolerate disease and physiologic changes of pregnancy. And again, we're talking about very, very mild cardiovascular disease. So therapeutic management, we want to do a thorough assessment with vital signs, apical heart rate, and heart sounds. And vital signs are important here because oftentimes these women also have hypertension. We want to monitor weight gain and peripheral edema. This gives us an indication of heart function. Is mom going into heart failure? Okay. Monitor fetal activity and signs of preterm labor. Assess the lifestyle and her ability to cope with the changes of pregnancy and the effects on her disease. And again, low salt diet, a DASH diet, if she has hypertension, is going to be helpful. Sometimes fluid restrictions to prevent CHF. Recognize signs of cardiac decompensation. I want you to know these. Okay, you will probably be asked on the exam. Shortness of breath on exertion, cyanosis of the lips and nail beds, jugular vein distension, tachypnea, chest pain with effort, fatigue, and a moist, frequent cough. So we want to stabilize the mom hemodynamic status to optimize placental perfusion. Again, perfusion through the placenta into the fetus is our concern. Reducing risks that lead to complications. So that would be things like monitoring her blood pressure, those lifestyle changes we talked about, like fluid restriction, low salt diet, education, counseling, including preconception counseling if not yet pregnant. They should really find out before they try to conceive if they're a candidate for pregnancy. Drug therapy, including Lasix, beta blockers, digitalis, and antiarrhythmics. And again, depending on the severity of heart disease, they may need to have these medications. It's important to educate patients that they have to adhere to drug therapy. Encourage good nutrition. We discussed that. Labor and delivery course is based on the severity of the heart condition. So a lot of women can deliver vaginally, but optimally the cardiologist will decide the mode of delivery. Some of these conditions, the patient can't have a vagal, any kind of vagal maneuvers like pushing because it can affect their heart. Okay, moving on to asthma. So the prevalence is increasing, kind of like everything else. It affects about 13% of pregnancies, associated with increase of infant death, preeclampsia, IUGR, preterm birth, and low birth weight. And again, it has to do with oxygen deprivation. Okay, if she has severe asthma, this is going to affect her own oxygenation, but her ability to provide oxygen to the growing fetus. The effects are dependent on the severity of the disease, as we talked about before. It can go into remission or become worse in pregnancy. And most of the time, it does go into remission. Or women have a very, very mild case of it, and so it's usually not a problem. However, they can have status asthmaticus, where they have a severe asthma attack and they end up in the ED. It can be life-threatening. The effects can be exacerbated by normal physiologic changes of pregnancy. And remember, we talked about respiratory. They're in kind of a respiratory alkalotic state because they try to breathe a little faster, and just all the anatomy of the fetus and the uterus pushing up on the diaphragm kind of inhibits effective deep breathing, so it can affect their breathing. So if you think about them having asthma on top of that, it just kind of exacerbates the effects. So therapeutic management, so they require aggressive treatment. We want to obtain pulmonary function tests if not done recently, because we need to kind of get a baseline, okay? And then usually they're going to improve. If they do have an attack, we give them a bronchodilator. It's going to open up the airways, decrease the inflammation, and the patient's going to have pretty much normal pulmonary function. So it is reversible with asthma, so that's one thing that we look for when we're diagnosing this condition. The goal is to prevent hypoxic episodes and preserve continuous fetal oxygenation. Again, oxygenation is the key. So we want patients to avoid triggers. We want them to use a bronchodilator for exercise triggered. There may be other triggers such as pollen, pet dander, other things a patient may be exposed to, dust. So they want to have that bronchodilator. They want to make sure, we want to make sure and ask them if they have a recent bronchodilator that's not expired. Because if they haven't used it for a year or two, it's probably going to be expired. A stepwise approach is used to treat with the least amount of medication. But again, this is going to be dependent on their severity of asthma. If they just have a mild intermittent asthma, okay, then they may just need a bronchodilator. But if they're getting to be more moderate, where they're having more frequent attacks, then they're going to probably need an inhaled corticosteroid added to that. So the medications, we don't really recommend oral steroids unless they have a status asthmaticus situation where they need systemic steroids. So we're usually going to use things like budesonide, which is an inhaled corticosteroid, albuterol, which is our short-acting rescue inhaler, beta-2 agonist, and then Celemetro is a long-acting beta-2 agonist that they may need to add if, their severity increases. So client education at the first prenatal visit is imperative. Use of drugs for asthma during pregnancy and drug interactions. It's very, very important for women to adhere to drug therapy when they have asthma. They don't want to be stopping their medications. The benefits do outweigh the risk to the fetus, so they need to be continuing to take those medications. Monitor their oxygen status in labor and pulse oximetry. Especially if they're a moderate to severe case. We want to make sure we're doing that. Pain management in labor to reduce stress. Continuous fetal heart rate monitoring in labor if they have severe asthma. Okay, moving on to anemia. So iron deficiency anemia is the most common anemia in pregnancy. And it just can be triggered by the changes in pregnancy. So we just have to kind of keep in mind that women need to be taking adequate iron supplementation so that they are getting enough iron so they don't get depleted in pregnancy. So it can be a false anemia. We talked about hemodilution and the increased blood volume. It kind of dilutes it, so it makes it look like they're anemic. And again, H&H in the first and third trimester are going to be a little bit lower. So 10 and 32% on the hematocrit is going to be a normal, and then 11 and 33 in the second trimester. So we can kind of expect that. Fetal risks include low birth weight, poor mental, and psychomotor performance. Okay, these can have profound effects on the fetus and brain development. So that's why we want to ensure mom is getting enough iron. And then we continue that iron supplementation, in the fetus and then through delivery by making sure that we do delayed cord clamping, because that's going to provide them with more iron stores up to 6 months of age. And then making sure that they have iron fortified formulas if they need it, because as their little brains are developing, it can really affect them if there's not enough iron. So clinical symptoms in the pregnant woman include fatigue, diminished quality of life, impaired cognitive function, headache, restless leg syndrome, and pica eating behaviors. And so this is where they kind of crave inedible things like dirt, clay, cornstarch. I've even had patients crave ice cubes, like where they eat ice one after the other, because they just are probably depleted in iron and other minerals. So that's kind of what leads to this condition. So we want to check their H&H to make sure they're not anemic. Okay, so therapeutic nursing management. So again, goals for treatment include um, just eliminating the symptoms and correcting the deficiency and replenishing iron stores. And this is usually just done in the form of oral iron supplementation. ACOG does recommend 30 milligrams per day. Most women are able to tolerate oral iron just fine. However, I have had patients where they've had to go in and have an IV iron infusion because they're not tolerating it or they're nauseated or something's going on. So we bring them in the hospital or infusion center and we give them a daily iron regimen for like a week. And then that gets them up to speed. So review the history, dietary intake, and symptoms she may have. Um, expect a normal decrease. We talked about that due to the hemodilution effect. Encourage iron-rich foods and take supplements with orange juice because this does enhance absorption of iron. And they should avoid like dairy and any kind of like calcium supplements or Tums or anything like that 2 hours before and after they take their iron because it does compete with the site. Okay, so question, your patient has been advised that she is anemic at 28 weeks and she needs to start iron supplementation. So what education would you include for the patient? Select all that apply. So take a look at that. So definitely B, she needs to take her iron with orange juice. She should increase her fiber intake because iron can lead to constipation. And D, she should expect her stools to turn darker. Some women will have black stool from iron. That's a really normal thing. So we just want to educate them on that so that they understand that they should expect that. Okay, sickle cell anemia. So just be aware this is an autosomal recessive disorder. And it's a defective hemoglobin molecule resulting in the sickle shape of the RBC. So that's generally what we see. It's most common in African American patients. The most adverse maternal outcomes in women can be preeclampsia, preterm birth, placental abruption, IUGR, low birth weight, and maternal mortality. Only one gene is required to be a carrier. So again, if you are testing a pregnant patient to see if the fetus has sickle cell disease, it does require the patient to be a carrier and the partner. If the patient herself is a sickle cell carrier, she does not manifest symptoms of the disease. Okay, so it's not really a concern. It's only if the patient has sickle cell disease herself where it's a problem. So it is important to screen prior to pregnancy. So we do screen pregnant African American women and those that are higher risk with ethnicity. And then increased intraprenatal surveillance of the fetus is important. So we do have to monitor that because again, we're more concerned about oxygenation. And then be alert for sickle cell crisis. And the symptoms of that include severe abdominal pain, muscle spasms, leg pain, joint pain, fever, stiff neck, nausea, vomiting, and seizures. And then carriers are getting asymptomatic. Okay, autoimmune disorder. So there's a slew of these, and just be aware that they affect women a lot more frequently than men. Okay, so anyway, it's localized target organs. So this can include the thyroid, or it can be like more systemic, like lupus or multiple sclerosis. Rheumatoid arthritis, those are some examples of some of these that we see. Lupus is kind of a systemic disease that affects many organs of the body. MS is kind of more of a degenerative disease of the muscles, and so we really watch them. And again, rheumatoid arthritis, is a joint inflammation and progressive disease. So these disorders, really in a nutshell, they tend to improve during pregnancy and they have more of an exacerbation after. Okay, so that's the important thing to remember. Usually postpartum, they're going to exacerbate. Okay, moving on to infections. So cytomegalovirus, this is a leading cause of congenital infection with morbidity and mortality at birth, and a sequelae. So most infants are asymptomatic, but they can be very serious, leading to permanent disability with in utero transmission. Okay, so it can be transmitted sexually or a lot of times contact with children infected in daycares. So if we have pregnant women that work in daycares, they're kind of really higher risk for this. So it's important to kind of get that history from them. The main thing is we don't really pick up on it because they may not become very, very sick with it. But what we do see is an ultrasound, we see markers in the fetus that something's wrong. There's nothing else really to explain it. And the main thing we see is a small head. We call that microcephaly. The head is measuring smaller in proportion to the other body parts. We also may see what's called an echogenic bowel, where part of the bowel will highlight white, and it kind of shows up that way that there's something going on. Cystic fibrosis, they can also have that echogenic bowel, but a lot of these viral infections, even like rubella, which we're going to talk about next, they can also have microcephaly. So if nothing else is really explaining it, we do an IgM and an IgG test on the patient to see if they could have been exposed to cytomegalovirus. And then rubella, we do test for that in early pregnancy. Remember, we do a rubella titer to see if they're immune to the disease. Because if they're not immune, there's always that risk that they could get exposed. And usually it's worse in the first trimester. Okay, so the earlier exposure, the more problems the fetus will have. And that includes, again, cataracts, small head, glaucoma, intellectual disability, and then again, that microcephaly. Herpes simplex virus, again, this is HSV. It's HSV1 or 2. We're more concerned with HSV2 and babies getting exposed to it during a vaginal delivery, because if the mom has active lesions during birth or upon rupture of membranes, because it can infect the baby in utero if her membranes are ruptured, or on the onset of labor. So generally what we do is we put the patient on prophylaxis at 36 weeks with acyclovir or Valtrex, and she's to take it consistently until she comes in to deliver. And if she's clear of any lesions after inspection of everything down there, she's cleared to have a vaginal delivery. So even if she didn't take the prophylaxis, if she's not reporting symptoms, or there's no visual lesions on the cervix, vagina, perineum, any of those areas, she can still deliver vaginally. Otherwise, she's going to be a cesarean delivery. And we've had that transmission before without the patient even knowing she had herpes. So it is really, really important to get that history when she comes in. Has she or her partner ever had herpes? We also ask them prenatally, is there any history of her or her partner having herpes? Okay, hepatitis B, we do test for that, as well as hepatitis C. And hepatitis B can be transmitted sexually. The important thing is transmission to the fetus. So a lot of them, most of them occur in the third trimester. If they're born to mothers with hepatitis B, if they get the Hep B vaccine and the HBIG, which is the hepatitis immunoglobulin, within 12 hours of birth, we can prevent chronic disease by up to 90%, okay, which is huge, because if babies go on to develop chronic hepatitis B after transmission, they can end up getting liver cancer from that. Hepatitis C is now checked as part of the prenatal panel, so you should be looking for that on your patients. There is a treatment now for Hep C, but they can't get it in pregnancy. Okay, so just kind of be aware of that. Varicella zoster virus, so this is maternal chickenpox, can be transmitted vertically in utero, and there is serious problems with the fetus if they do contract congenital rubella. So they can get lesions, it can lead to spontaneous abortion, chorioretinitis, cataracts, growth restriction, microcephaly, and early death. And it's not a pretty picture when a baby has congenital varicella. That's why we do check varicella titers as well. Not all OBs are consistently checking varicella. Some of them just may ask the patient if they've ever had chickenpox. But personally, I've had a case where a patient had both chickenpox and the vaccine and came back non-immune to varicella. So I think it's really important for these patients to get the titer. HIV virus, so perinatal transmission is decreasing significantly due to the antiretroviral agents now. So if mom is consistently taking her medications, transmission rates are super low, can go down to about 1%. If she's not, though, it increases significantly to like 35 to 40% roughly if she doesn't take the medications. Okay, so breastfeeding is contraindicated with HIV because it can directly transfer HIV through the breast milk to the baby. So we want to decrease our viral load. That's really the goal. If mom is low, it's something like 2,500 copies, I want to say. She can deliver vaginally, but otherwise, if they're high, she'll be a cesarean delivery just because we want to decrease transmission to the baby. Okay, so other vulnerable populations, we have those young patients, adolescents, 13 to 19, although we do see pregnant patients as young as like 10, 9 or 10. It's happened. So we do have to just keep that in mind. Pregnant women over 35, obese pregnant women, women positive for HIV, women who are abusing substances, and homeless women. So with substance abuse, this is becoming a really big problem now. There's a lot of fetal vulnerability, teratogenic effects, and addiction consequences. And so effects of common substances. So if you look in your book on page 742, it kind of gives you a list there of things to look at. Fetal alcohol syndrome, we're going to talk about that. Caffeine, nicotine, cocaine, marijuana, opiates, and narcotics. Which are high risk for neonatal abstinence syndrome, sedatives, and methamphetamines. So fetal alcohol is 100% preventable. We teach women that no amount of alcohol intake in pregnancy is safe. And we don't know the amount that could cause harm. So we have to educate patients not to do it. They just need to abstain 100% to avoid this happening. And they could just have one drink and end up with a baby of fetal alcohol, or they could be a really heavy drinker, of course, but we just don't know. And there's a full spectrum of birth defects, including like facial features to intellectual disability. I mean, it can be very mild, but very severe. And the damage can occur at any stage of pregnancy. So it doesn't matter if they have that drink in the first trimester. It doesn't matter if they have it in the third trimester. They can still give their baby fetal alcohol syndrome. Congenital defects and behavioral problems do result from exposure lifelong. I mean, it really messes them up for life. Okay, so it's a serious thing. Okay, so caffeine is a stimulant, so an excessive amount can lead to stillbirth, preterm birth, reduced birth weight, and growth restriction. And we're talking massive amounts of caffeine. Okay, so coffee decreases maternal iron absorption as well. So they really don't want to be drinking a lot of this. Okay, they can have a cup or two a day, but they should limit it really to 200. Some literature says 250 milligrams of caffeine per day. They should avoid the energy drinks. Those tend to have a high amount of caffeine in them. Nicotine has adverse health consequences. So nicotine replacement is considered safer than smoking. So we do tend to get women on the patch. It is a little bit better for them to be on that rather than smoking. So nicotine exposure can result in spontaneous abortion, ectopic pregnancy, preterm labor and birth, IUGR, PPROM, hypertension, low fetal iron stores, placenta previa, placental abruption, SIDS, congenital defects, and altered brainstem development. So you can see there's a whole laundry list of things associated with nicotine. Okay, marijuana. So we know that there's an increase in usage due to the states legalizing this. It is most widely used illicit drug in the U.S. The prevalence in pregnant women is 10 to 15%. Now that may seem like a low number, but it's not. That's significant. It does cause tachycardia and low blood pressure. Some evidence it can lead to preterm birth and spontaneous abortion. And then even more recent studies show an increased incidence of fetal growth restrictions, stillbirth, long-term brain developmental issues affecting hearing, behavior, and memory, low birth weight. Women who use marijuana should not breastfeed. Okay, so literature is becoming more clear on that because it can affect brain development. Okay, so this is, really huge information that we need to pass on. So opiates and narcotics include heroin, oxycodone, methadone, dilaudid, codeine. So it is a growing problem in pregnancy. Women, it leads to medical, nutritional, and social neglect. It can lead to widespread withdrawal in the newborns, and neonatal abstinence syndrome. So that's the main thing that we're worried about with these babies in the NICU is withdrawal. Okay, and withdrawal in pregnancy is very dangerous to the fetus, so they must be regulated, usually by a maintenance program with close supervision. And they have these clinics that actually manage this. Heroin is the most commonly illicitly used opioid. Management includes buprenorphine. That's usually kind of becoming the more go-to, even over methadone, because buprenorphine is just better. Prenatal care and 12-step programs. So we need to focus a lot on helping these women, okay? Especially women that want to be helped. You have those women out there that don't want to be helped. You try to reach out to them and help them, and they don't want to be helped. But we do have opportunity with women who do. Okay, so other substances include methamphetamines, which is a highly addictive to the CNS. It's a stimulant. It leads to adverse perinatal, neonatal, and childhood outcomes. Chronic use can lead to psychosis. Few studies done, but can be linked to preterm birth, low birth weight, placental abruption, fetal growth restriction, and congenital abnormalities. We're kind of seeing more of these effects. That's why the studies take so long, is because we don't see effects until the child becomes school age, and then they're a little bit behind developmentally. Cocaine is another one that we see. It affects infant development via intrauterine exposure. And this one is the one that leads to vasoconstriction, placental abruption, usually very high blood pressure, tachycardia, and then these have effects on the fetus as well. So adolescence, this is a very crucial time for this population of transition to adulthood. So they have higher physical risk factors. So we need to screen for social, intimate partner violence, food insecurities, and financial instability. And sometimes when their parent status is risky, it affects them. Oftentimes they do not have supportive parents. Psychosocial impact in pregnancy, so they have loss of self-esteem, societal discrimination, destruction of life projects, and prolonging of poverty. So examine own beliefs as caregivers. So we kind of have to look at how do we feel about these things. If it was our child, how would we feel? Have the ability to communicate with the population. So higher risk for obstetric complications. So those include things like preterm labor and birth, low birth weight of infants, preeclampsia, iron deficiency anemia, inadequate nutrition, and postpartum depression. So how can nurses have an impact on adolescent pregnant population? Okay, so kind of think about that. Like, what can we do to help improve the outcomes for these pregnant patients and their babies? There are programs available for teens, that help them with WIC to get food, shelters, all those kind of things can be helpful for these patients, homes for pregnant women. Ethical and legal concerns, they are minors, a lot of them, but they are emancipated once they're pregnant and become parents. Okay, so maybe they don't really have the ability to make adult decisions, so that can be difficult. Okay, obesity. We know this is a growing problem. Okay, it's an epidemic. It's becoming very, very much a problem. So it can lead to many, many complications, maternal morbidity and mortality, including like preeclampsia, diabetes. And these implications trickle down onto the offspring. And so the offspring may have difficulty with weight management later as children. So this is really important. Also leads to congenital defects. If their pre-pregnancy BMI is super high, we're seeing that they have kind of similar outcomes and problems of women who have diabetes. Just due to the excessive weight and the excessive calories. So we really need to do a lot of education with these patients because it does set them up for a slew of complications, which you can see there. And then management, so requires individual pre-pregnancy care, dietary adherence, okay, or interventions, decreasing the risks, okay, of comorbid conditions. So if we can try to help get these women more healthy, that's going to help, okay, and decreasing obesity in the offspring. We talked about that. And then exercise initiation. So if we can get them to exercise and eat better, and avoiding postpartum rate retention. All right, that does it for this slide set. I hope that you found this informative. And if you have any questions, please reach out via email. Thank you.